Good afternoon, everybody. It's a real pleasure to be here today, particularly for me, as it was 15 years ago, more or less, that I first became interested in this area. One reason being my youngest daughter starting to experience febrile seizures, and around about the same time reading Professor Carlini's work on cannabidiol back in the 80s. So to be invited here today to talk about this is particularly important and meaningful for me. So, where to start? I think Professor Carlini actually set the scene very, very well at the beginning today, where he was saying, well, why cannabis again? Why now? This seems to be a topic that occurs again and again and again. And I hope during the course of the next 20 minutes or so that I'll be able to give you, rather than any regulatory information or legislative information or any particular beliefs that I hold, I hope a clear background in the science, the preclinical science particularly, that underpins the science, the effects of cannabidiol that we may be seeing in some of these individual patients, and how the road may appear in the next few months, the next few years, which I hope will directly answer or provide some of the answers to the urgent questions that some of the parents of the patients posed at the end of the last session. Now, I don't have all of the answers, and for the ones that I don't have the answers for, I do at least hope that I can give an indication of some of the timescales involved. So, to begin, an important point that I want to make at the outset is that when we're talking about, say, some of the activity in Colorado in the US at the moment, particularly with Realm of Caring, with Charlotte's Web and so forth, we're talking about a CBD-rich cannabis extract. It's an extract that still contains a significant amount of THC, which we know is psychoactive. Okay? Now, I'm also going to go on and talk about a number of clinical trials that are in progress in the US and about to start in Europe using cannabidiol, and here we are talking about the pure compound. There's no other plant components in there, none of the terpenoids and other things, there's no THC in there. So when people talk about CBD, the first question you should ask them is, what's the composition? What's in it? Are we talking about pure CBD? Are we talking about a hemp-based extract that contains CBD plus a load of other things? Or are we talking about a cannabis extract that also contains significant amounts of THC? Ask that question first, and then start to look at the rest of the evidence. So I'm not going to belabor the detail on this slide because time is short, and I hope I'll be able to get the thread of the information from my other slides. So where did we start with cannabis and epilepsy in the clinic? Well, it was actually thousands of years ago. If you like, almost prehistorically, there were mentions in Ayurvedic medicine and traditional Chinese medicine, and then around about 1,000 years ago, you've got Arabic writings about the use of cannabis against seizures. I'm not going to belabor the details. It didn't actually appear over here in the West until the 19th century, when you had a number of pioneering physicians who all reported use of cannabis, crude cannabis extracts against seizures. In actual fact, it was J.R.R. Reynolds, Queen Victoria's personal physician, who actually identified as well that cannabis was particularly useful in treating convulsions. And now, I'd like to make a historical point here as well, if I may, which highlights how difficult epilepsy is to treat. Around the time that Reynolds was doing this work, there was another chap, William Gowers, who, if you like, is considered the grandfather of epilepsy treatment. And he was around when they first introduced what is considered the first modern treatment for epilepsy, potassium bromide. It's no longer used because it's a very nasty drug, but it was the first modern chemical medicine for epilepsy. And of all the people that were treated, Gowers discovered that about 35% were resistant to that treatment. Now, what's the proportion of epilepsy patients today that do not respond to all the treatments that we've developed and have tried? It's the same 35%. In 100 years, all we've done is improve the side effect profile. So there's the important thing to remember here is the fact that we've come an awful long way, we've learned an awful lot, but there's still a huge unmet clinical need. And I think where we go in the next couple of years with CBD may offer some hope in that regard. So really between Reynolds and Gowers and today, What's happened since then is we've had lots and lots of numerous isolated case studies, whether it's the ones that we've seen today or the ones that have been reported in the literature. Most of those studies report anticonvulsant effects, but there are a finite number of reported proconvulsant effects. There have not been any properly powered, so enough participants to actually do proper statistics on, randomized, blinded, placebo-controlled clinical trials. These are the gold standard by which we decide a drug works or it doesn't. Now, that is not a helpful thing to say when an individual is sitting there with a child with epilepsy in their arms. However, we've also got to remember that it's the only way to determine if a medicine will benefit those 12.5 million people who don't get benefit from the treatment at the moment. It's the way that you go from a single individual to an entire population. It's not a matter of passion, empathy, sympathy, or emotion. It's simply the way that one advances the case to benefit the largest number of people. So the limited trials that have been performed are all relatively small. They've been limited, they've offered some conflicting results, and really that comes not out of poor science being done by the people involved. It simply comes about from limited resources or other constraints that are imposed. It doesn't let us draw a final conclusion. Most recently, last year, Catherine Jacobson and Linda Porter published a survey of parents using the realm oil that we've heard so much about that suggested that there's cause to be optimistic there. One of the most interesting things in that paper is actually one of the children who had a dramatic reduction in seizures but was taking a CBD-only product, suggesting, as we've seen before, that CBD alone can be very, very useful without necessarily having the THC. So before I get into some of the modern preclinical evidence that my group have done in animal models over the last sort of 6 or 7 years, a very, very quick review of the literature. If anybody really wants the detailed summary of this, ask me. I'll happily give you the spreadsheet that took me weeks to compile. I want to make a distinction between THC and CBD. If you look at all the animal models in which these compounds have been tested, in THC you've got 6 species, 31 different models or experimental designs, a huge dose range. About half the time it's anticonvulsant. The rest of the time there was no effect, but there is a significant number where a proconvulsant effect was seen, so it worsened seizures, and I'll come back to this point in a minute, in fact that we don't properly understand it yet. Interestingly with CBD, you've got 2 species, rat and mouse, 21 different models, a huge dose range. In 8 out of 10 cases, it's anticonvulsant. In the cases where it wasn't, it had no effect, and arguably, based on what we know now, that was due to the fact that people were using very, very low doses. In no test that's been done, in any of those 21 studies, have we ever seen a proconvulsant effect. And I'll come back to the safety and the tolerability of this drug later on in the talk. So I'm going to spend a little bit of time on THC, not as a scare story approach, but I just want, this is something that I think gets not swept under the carpet, but doesn't get mentioned or doesn't get dragged out, and I think does underlie some of the reticence, some of the concern, some of the anxiety that regulators and legislators do have about cannabis-based medicines. If you look at most of the studies that have been done in animals with THC alone or synthetic cannabinoids, it's mostly acute models of seizure, and in the majority of cases, as we saw, about 6 out of 10 cases, 60% of the time, you see an anticonvulsant effect. However, when you get up to the higher doses, or in some models, you see a proconvulsant effect. You see a reduced latency of seizure, or you see an increased severity of seizure. And on top of that, you also tend to see THC will reliably introduce or cause seizures. This is from a National Toxicology Program report from 1996 that the US government did. THC administration will reliably cause seizures, most often worse in females than males, in a lot of laboratory species. So, for example, mouse, rat, rabbit, and so on. Now, this isn't something that we've seen in other test species, such as dog and pig. It's not clear in the human condition how this relates, and so it is a big unanswered question. I think remains a concern, rather than an absolute no, we shouldn't be going in that direction, but it does remain a concern, and it's not a concern we've necessarily got with CBD. Now I've got a slide here on CB1 antagonists, which are actually blockers of this cannabinoid type 1 receptor. I'm going to skip straight over that because, to be honest, we're very tight on time, and it doesn't really tell us a great deal more, other than to perhaps, on my next slide, illustrate some of the dichotomy that occurs here with THC and blockers of the CB1 receptor. So at the moment, clinically, blockers of the CB1 receptor are contraindicated in people with epilepsy because preclinical studies have shown that these drugs cause convulsions. CB1 agonists, so things like THC, are contraindicated in people with epilepsy because the National Toxicology preclinical study showed that it has proconvulsant effects. So whether you activate the receptor or block the receptor, it seems to cause some proconvulsant effects in some situations, in some species. So there's a huge amount of confusion. And then this is on top of the fact that, say for example, if you look at a population study, being a cannabis smoker actually reduces your chance of developing epilepsy. So a lot of people are still scratching their heads very hard about what the story with THC and epilepsy is. And this was really the starting point for me some time ago, and for a lot of people working on this, that if THC-containing approaches remain uncertain and there is some risk associated with them, or potential risk, is there any therapeutic potential for non-THC components of cannabis? So a lot of this is data that's come from my group. The majority of it has been backed up by others publishing elsewhere or using similar models. So I'm going to try and run through it with an overview, a broad brush, because I think we've got a very broad audience here, and I'm not going to bore you to death with the technicalities of the models that we use. So firstly, this is 2 in vitro models. So we take slices from rat brain whilst they're still alive, and in the same way as an EEG electrode is put on your head, we use a series of 60 electrodes on that slice. That's the hippocampus that the last speaker was talking about, and we induce epilepsy-like activity. And you can see here, without CBD present in this one model, you've got large amplitude epilepsy-like waves. In the presence of CBD, it's not abolished, but it's certainly abolished. But when you use another model, this is blockade of potassium channels, you get similar large amplitude epilepsy-like waves. In the presence of CBD, you get an attenuation, you get a drop down of this effect. And so, in vitro, with some of our first studies, cannabidiol alone, this is pure cannabidiol, not an extract, just the pure compound, produces significant anti-epileptical effects at concentrations greater than 10 nanomolar in both of these models that we've used. We then, this is the quantified form of this data. I'm going to skip past the complicated and scary graphs with all the stars on, and simply point you to the bottom graphs here. These represent the overall power of these epilepsy-like signals that we can measure from these slices. The black lumps are the activity without CBD present, and the larger the area under these curves, the stronger the activity is. The grey overlays that you can see here are the activity in the presence of cannabidiol at 100 micromolar, and you can see that they're significantly attenuated. It's markedly dropped down. We then went on and studied these in animal models, whole animal models of seizure. So these are either electrically induced seizures, seizures induced by an audio pulse that particular mice are susceptible to, or by using a drug called pentylene tetrazole, which induces generalized seizures. So when we saw those EEGs in the last talk, where the seizure activity spread across the whole brain, in these 3 models, it's that type of seizure that's being caused. Now, in all of these cases, at doses of 50 milligrams per kilogram, 100 milligrams per kilogram here, or 100 milligrams per kilogram in this one, we see significant reductions in the measures such as the severity of the seizures, hind limb extension, which is a measure of seizure severity, or the percentage of clonic seizures in these animals with pure CBD treatment. So we see significant effects across a variety of generalized seizure models. We then went on and had a look at pilocarpine-induced seizures. These model acute temporal lobe seizures and also status epilepticus. They're a particularly hard type of seizure to block. And again, we see significant results or significant effects at reducing seizure activity with cannabidiol. We then went on and looked at penicillin-induced seizures. These induce partial seizures, so a seizure that's confined to a single part of the brain that later spreads to include the whole of the brain. And again, we see significant anticonvulsant effects of CBD in this model. We then had a look at the interaction between another cannabinoid, CBDV, which is a propyl variant. It's got a slightly shorter side chain than CBD. It's also non-psychoactive like CBD. And we had a look at the interaction of these 2 compounds because it's another one that we're working on at the moment, and it's another one that's just gone into clinical trials. Here, we found that CBDV is actually marginally more potent, it's more effective, so it starts working at a lower dose and it has a slightly higher peak effect upon seizures than CBD. And when you give the two together, I'm not going to go through the painful detail of an isobolographic analysis for you, but the effects of the two compounds are additive. They're not synergistic, but they don't antagonize each other, they don't work against each other, they add their effects together. We also looked at whether CBDV, in this case, and I can say just as overall, but I'm going to jump backwards and forwards a bit between CBDV and CBD here, is the two behave very, very similarly in our hands in the models that we've tried. It's effective orally, so it works when given by mouth to rodents, and we've also confirmed that the reduction in seizure that we see is also confirmed by the expression of changes in gene expression that are consistent with reduced seizure activity. So these two genes tend to increase their expression with stronger seizures. In animals that have been given CBDV, that expression is reduced. We've also had a look at tolerability, and this is probably one of the most pleasing results that we've seen in the group. Down the left-hand side here, you'll see the results from what we call a static beam test. The animal moves across a bar to a nice safe home cage, and you can count how successful the animal is at doing the task, how many foot slips it makes, and the distance it travels if it does fall off. And when we look at conventionally used anticonvulsants like valproate, ethosuximide and phenobarbital, you can see at therapeutically effective doses they all produce significant side effects. So the animals don't pass, they fall off more frequently, they suffer more frequent foot slips, or they don't travel as far. At CBDV and CBD, at the therapeutic doses we've tested, there is really no effect at all on their performance in the static beam task, demonstrating that these drugs are extremely well tolerated when compared to conventional anticonvulsants. We've then had a look at CBDV in a chronic model of epilepsy. Now, a lot of drug development in epilepsy tends to focus on the fact that you induce a seizure in an animal once, and that animal is an otherwise healthy animal. That's not the same as an epileptic brain, so if you really want to know how a drug performs as an anti-epileptic, you want to test it in an animal that is epileptic, not a healthy animal that you've just given a seizure to. So we use a model here that very closely resembles temporal lobe epilepsy in humans, and here we see a significant effect of CBDV treatment. This was given orally over 3 months, and you see a significant reduction in seizures towards the end of treatment. We've gone further with this and also done tolerability testing in these animals, and animals that receive the drug animals that don't receive the drug, who are epileptic, perform less well than ordinary animals. Animals that receive the drug and are epileptic, some of that detrimental effect of the disease is removed by treatment with the drug. We've had a look at effects on working memory and reference memory, so how they perform in cognitive tasks. And whilst the disease itself worsens their performance in this, treatment with the drug doesn't make it worse still, unlike many of the conventional anticonvulsants that are available today. We've also looked at whole genome expression in these animals, so every single gene that these animals express, we've looked at how disease changes that. Disease changes approximately 300 different genes, and treatment with CBDV reverses that change, or reverses 75% of those changes, providing us with a molecular marker that the drug is efficacious. I'm going to skip over these 2 slides because they really are hardcore mechanisms, but I'll be happy to talk about these to people if they're interested. Important take-homes from the mechanisms is that we've shown that CBD is not a sodium channel blocker, so people using it in Dravet can have some confidence that you're not going to end up with a situation like phenytoin or carbamazepine where it actually worsens seizures, and it is certainly not acting via a CB1 receptor mediated mechanism. Our current work over the next few years is really focusing on some of these mechanisms, and our current leads are calcium modulation and upregulation of neuropeptides. My final slide, because I know the guys here are waiting, is really my initial effort to try and answer some of those pressing questions that you were asking about. What's safe to take with this? What should the doses be, and so forth? And there's a review coming out in Epilepsia next month that Oren Davinsky and I and a number of others have written that have tried to draw an awful lot of this information together for people that need it. What you need to bear in mind with this compound is that it's very highly lipophilic. It dissolves in brain, it dissolves in fatty tissue. So when you're starting treatment, you need to load. You won't get peak effects until you've been dosing for a number of days. It's extensively metabolized by liver by some of these CYP enzymes, and some of these enzymes can affect carbamazepine or phenytoin levels. This is particularly relevant for non-Dravet patients. You also find that you get inhibition of some of these CYP enzymes, and it seems to be emerging now that particularly patients who are taking clobazam, high doses of CBD can affect the metabolism of clobazam, upregulating or increasing blood and brain levels of clobazam. So clobazam doses may need to be moderated down a little bit to avoid benzodiazepine type side effects of increased sedation and so forth. There are references for all of those there if you want to chase those up for the specific science behind it. So where are we going now? Very last bit, preclinical. We're looking at effects in the Dravet mouse model with colleagues in the US. We're also looking at febrile convulsions and tuberous sclerosis as possible indications, but our main focus is looking at the underlying cellular mechanism of this drug. Clinically, which is what you want to know for the US and the UK, CBDV has just finished phase 1 human clinical trials successfully, and the intention is that GW Pharma will move into phase 2 safety tolerability trials in epilepsy at the end of this year. CBD, there's a phase 2 safety tolerability trial in pediatric epilepsies has begun. This is Orin Davidsky's trial out of New York and a number of other centres. And a phase 2 double-blind randomised efficacy trial in Dravet is due to start at the end of 2014. And I expect a number of you are already familiar with the named patient use that's going on in the US anyway. That's it from me. More or less the time. I apologise if we've gone over by a couple of minutes. It just remains to thank all of the people behind me standing up here today, which is the awesome team that have worked with me really over the last 10 to 15 years since we started this. And I'm incredibly pleased that not only have we managed to convince the pharma industry that this is worth taking forward, but also that there's some incredibly brave people out there on the front line who are willing to put their reputations, lives, and so forth at risk and at stake to try and drive this forward. I hope some of this information is useful. Amanda mentioned the American Herbal Pharmacopoeia earlier. I've written a complete monograph on all of the preclinical, all of the clinical evidence of cannabis and the isolated cannabinoids. It's freely available for download from the AHP site. There's no paywall, there's no pay-per-view or anything like that. So if you want the compiled information in one place, www.ahp.org.